Good evening. Welcome to Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist, and I help people avoid heart attacks and strokes. I started Apollo Cardiology in 2019 and been doing these Instagram lives since at least 2020. Every Monday, 6 p.m. Central Time, you submit your questions. I try to answer them, help you guys become heart attack proof. So lots of good questions this week, so we'll just jump right on in. Pros and cons of a calcium score test. There are many. It's a test I've been doing since at least 2013, since I first became more aware of it. It's a non-invasive test that looks at hard calcified plaque in the coronary arteries. It's a good risk stratifier. It does not tell you how much soft plaque you have, so that is the con. It only tells you the hard plaque, but they come together. If you have hard plaque, you'll have soft plaque. So it's in the newer lipid guidelines. If you have a calcium score test that's above 0, you're at higher risk. Over 400 is high risk, over 1,000 is very high risk. And in the new guidelines, there's LDL target goals based off your calcium score test. If your score is abnormal, you don't need it generally repeated ever again. But if your score is 0, probably 3 to 5 years later, you should check it again. And for those that have already had a prior cardiac event, heart attack, stroke, stents, or bypass, you never need the calcium score test because you're already high risk, and this test won't help you stratify you into a low risk category. Question is, the person says, I'm an overabsorber. What do you think about plant stanols? They may block some of the cholesterol being reabsorbed in the gut. The majority of the cholesterol in the gut is coming from your body's production, and the liver is dumping it into the bile, into the gut. The plant stanols will have an effect on blocking some of the reabsorption, but it's not that significant in my experience. So if people want to try them, they can, but they do have to make sure that they're not a person with phytosterolemia, very uncommon disorder, but if you do, then you reabsorb a lot of those plant sterols into your bloodstream, and it potentially is going to be more atherogenic. So don't do it willy-nilly. You want to be doing it with monitoring of your labs. And it's one of the ones where if it works for you, you should notice it's working within 3 months. If it's not working, pick a different agent. Do I agree with the pediatric LDL recommendations? What do you think kids should, and it cuts off. I'm a adult doctor, but I was interested in congenital heart disease, so I did do an extra month in my cardiovascular training. But the guidelines are that patients down to 9 should be screened for familial hyperlipidemia and treated if they're homozygous. But the earlier you can find patients who have significant dyslipidemia and treat them, the less likely they're going to show up in their 40s, 50s, and 60s with vascular disease. So I think everybody should have their lipoprotein A checked at least once, and I've been doing that since at least 2013. And I think checking an LDL cholesterol, while it's not perfect, is a good start point because it should not miss people who are at very high risk at an earlier age. Somebody says that they really messed up with chocolate eggs, cakes. Possible to get rid of it before it becomes fat. So possibly, but don't beat yourself up too much for kind of a dietary adventure on a holiday. The best thing to do is just literally walk it off. So if you're going to eat out of your ordinary pattern, go take a walk 15 minutes after you eat. Activate those GLUT4 receptors and clear that from your bloodstream so it is not stored as a triglyceride in the later fat. Does resting heart rate give any indication of cardiovascular disease? Not directly. Most heart rates will fall between 60 and 100. If you have a resting heart rate that's below 60 and you're an athlete, that can be normal. But if you're not, sometimes it's a marker that you have hypothyroidism or you may have sinus node dysfunction. If you have heart rate over 100, you could have inappropriate sinus tachycardia. It could also be atrial fibrillation. So it's not a definitive that you have cardiovascular disease. You need further testing potentially. Does heart rate increase with age? Not necessarily, and it may decrease with age as people start developing sinus node dysfunction. The sinus node stops firing and patients end up with pacemakers. Can mitochondria be transplanted to the heart? I think this is in experiments, kind of research at this point. This is not something for prime time. From a functional cardiology perspective, how do tick-borne pathogens damage the heart? Definitely not my area of expertise. I have seen some cases of complete heart block from Lyme disease. May have seen one case of Rocky Mountain spotted fever before. So not something that I'm well versed in. It usually damages the conduction system. And could the tick illness cause ongoing damage or drive arrhythmias like PVCs? Yes, possibly, definitely could do that. Is red meat a poor choice of trying to avoid heart disease? No, there's no data that red meat is going to contribute to cardiovascular disease. You need to optimize your dietary protein, and red meat is a good source for many people. Some people are sensitive to saturated fats affecting their lipoproteins, not everybody, so test, don't guess. If you are, then eat leaner cuts of red meat if you're open to eating it. What's your approach to treating atrial fibrillation? It is something that I know a lot about. I've seen thousands of cases of AFib in my life. It's not my primary focus anymore. I more focus on atherosclerosis and hypertension. But the kind of take home with AFib is that it's first about evaluating the risk of stroke for those people. There's a risk calculator called the CHADS-2 VAS score. The higher the score, the higher the risk of stroke, and that's what you're trying to reduce. So patients with scores over 2 should highly consider anticoagulation unless there's a compelling reason not to, like excessive bleeding risk, fall risk. But that's the key, is you're trying to lower stroke risk. Person can't tolerate anticoagulation. There are left atrial occlusion devices that may be beneficial in some instances. And then you treat the AFib if the person is symptomatic. So you can use rate controlling medications, you can use rhythm controlling medications, and if the person is highly symptomatic and intolerant to meds, or they have heart failure because of AFib, then an AFib ablation should be potentially considered. What do you do when you have narrowing of the arteries? You test, don't guess. Atherosclerosis is very common. It is not something that you have to die from or have strokes or heart attacks from, but you do got to get to the root cause of why you are developing atherosclerosis. So it starts with the damage of the glycocalyx and underlying endothelium. There's an inflammatory and oxidative stress response, and the lipoproteins play a role. It's not the primary role for many people, so it's not all about cholesterol, because half the people who have heart attacks have, quote, normal cholesterol. But work with somebody who understands how to get to the root cause of atherosclerosis and treat. That's what we specialize at Apollo Cardiology, is finding out that and stopping that process, and potentially even getting the plaque to shrink. Can ApoB be lowered by diet? The short answer is yes, but not everybody. It tends to be patients who have ApoE4 alleles and they're changing up their fat concentrations, or persons who are insulin resistant or pre-diabetic, and they're essentially doing the lifestyle work that improves their insulin sensitivity. So it can be, and it is always recommended that that is part of the lifestyle recommendations, is to clean up the diet if it isn't already. But you want to start with risk. How much plaque do you have in the arteries? The blood markers, you can track them, of course, but if you have plaque, you only want to use lifestyle interventions for 3 to 6 months. And if you can't get to your ApoB goals with lifestyle interventions, then consider pharmaceutical interventions if you're at higher risk. And as stated earlier, the CT coordinate calcium test is a good risk stratifier for those people. If your calcium score is 0, then maybe you have more time to continue to work on your diet. If your score is not 0, particularly if your score is over 300, which is the equivalent of you've already had a prior heart attack, you should consider pharmaceuticals at that stage. And I still will use supplements, but supplements are generally not that potent. And again, you only have really a 3, maybe 4 month window that if supplements work, fine, but if they don't, consider more potent agents, particularly if you're at high risk. And a question, is the Boston Heart Cholesterol Balance Test useful in determining an optimal diet? It can help guide it. So can the fatty acid balance test on the Boston Heart panel. You can then look at how well the person's absorbing the different fats that they eat. And if the person's a hyperabsorber of cholesterol, then maybe they're not going to want to have as high of a fat diet in some instances. Doesn't happen to all, but sometimes it can help guide it. But I use it more as a marker of how well are certain lifestyle interventions and medications or supplements going to work for them more than just diet. All right, and those were excellent. Those were all the pre-submitted questions, and I saw a couple comments dropping in, so I know there's a couple more questions, so we'll answer them. So I see one person that I'll be seeing later. All right. Question, what's your thoughts about the new cholesterol injections for those that can't tolerate statins? So those would be the PCSK9 inhibitors. The most common ones are Repatha, Praluent, and there is a twice-a-year injection called Ilisclerin or Leqvio. I have patients who take all three of these agents, not all at once, but I've had patients utilize all of them. They do work well. They block an enzyme called PCSK9, and I won't bore you with what it actually stands for. But PCSK9 is an enzyme that breaks down the LDL receptors. The LDL receptors sit on the outside of your liver, and they clear the LDL particles from the circulation. So think of them like a docking station that's grabbing the cholesterol particles out of the bloodstream, delivering them to the liver. When that enzyme breaks down the LDL receptor, the receptor goes back into the liver essentially, and the lipoproteins keep circulating around in the blood, trying to find another receptor to get cleared from. If you block that enzyme, then the receptors stay out longer, clearing the lipoproteins. So think of it as like they're working overtime. There are families that have something called loss of function PCSK9, and I know very likely my great-grandmother had that. She lived 106 years old with no, significant vascular disease. Probably had LDL cholesterols in the 30s or 40s with no medicines. So it is possible that you can live your life with an LDL cholesterol under 40 and not have any major issues. So the medications work well. The downsides really for the time being are that they're injections, and right now most of them are twice a month. The Leqvio is twice a year, but the oral PCSK9s that are coming, the only other downside for many people is just the out-of-pocket cost if insurance doesn't cover these medications. They are not necessarily first line unless somebody has familial hyperlipidemia or they've had a recent cardiac event and they're already on the maximally tolerated statin and you're trying to lower their numbers even further. So it does depend on insurance coverage for some people. When those drugs first came to market, they were ballpark about $16,000 a year out of pocket. They dropped down to about $5,000 or $6,000 a couple years ago when bempedoic acid came out. And now there's actually a direct to consumer model with Repatha, which I believe is a little under $300 a month if insurance doesn't cover it and the person wants to utilize it out of pocket. But they work very well. They're more potent than statins in many instances. There's some data that will lower lipoprotein A, maybe up to 30%, and not a lot of side effects. So they're usually a very good option for patients who are statin intolerant. All right. Do I have an opinion on nattokinase? Yes. So, but the real question is, what is the indication for natto? High fibrinogen? Maybe. But the idea that it's going to significantly lower lipids, blood pressure, reverse plaque, that has not really been confirmed. A lot of people want to, kind of quote this Chinese study where they did 10,800 FUs of nattokinase. The challenge with that study was that there was no placebo group, so it wasn't blinded to the people. People who took the supplement knew they were taking it. The investigators knew what people were doing. They're also all supposed to be taking 3 of the 3,000, I believe it was like 3,400 or something like that, FU tabs. They're supposed to take 3 of them, and many people are only taking 1, so not everybody was even taking the 10,800 units. And then, well, many people always get kind of concerned about who funds a study. This one potentially had a significant bias. 5 of the 10 investigators of that trial own stock in the company that sells the nattokinase that was used in the trial. So it's not saying that they're necessarily falsifying data, but it's one observational trial. It's hypothesis generating. It is not, proving that that actually happens. So don't usually recommend nattokinase for the great majority of people. There might be some very special cases. I do not recommend it, on a top of an anticoagulant or an antiplatelet therapy because the risk of bleeding can increase. There are case reports of brain bleeds with nattokinase. So as a physician, first, do no harm. Next question, thoughts on Plaque-X and EDTA. EDTA, if you have a heavy metal burden, it's reasonable, but mainly if you're diabetic, that's what the TAC trial showed. The TAC2 trial really did not show much benefit with chelation therapy in the non-diabetics. And Plaque-X, while it may be interesting, I don't believe it's worth the IV infusions to try to utilize it. It doesn't really reverse plaque like they say it does. There's an oral form. If people want to try the oral form, I think it's low risk, but I would not do IV Plaque-X. All right, so those were the questions and comments tonight. I appreciate your guys' time and attention. I will be back Monday, 6 p.m. Central Time, usually, but when I travel, sometimes I postpone those dates. So I'll let you know if there's ever a postponement, but I appreciate your guys' questions. It always helps to stay up to the top of mind of like what people are interested in learning about, because I can talk about this with my patients, and then the questions my patients ask me are the same things I'm going to share with you guys. So hope you guys have a great night, and we'll see you next time.